Again, welcome to the February 18th, 2021 speaker program for the World Affairs Council of Central Illinois. This is the fifth program for our current business year, which runs from July 2020 through June 2021. My name is Bruce Strom, and I am the current board president for the current business year. I want to thank you for attending tonight's program and for supporting World Affairs Council of Central Illinois. The World Affairs Council of Central Illinois is also referred to by its acronym for its name. The acronym is WACCI, WACCI. WACCI is a chapter of a national organization called the World Affairs Council of America. Our chapter was established in 1988. The mission of WACCI is to provide to residents of Central Illinois communities information about foreign policy issues and international relations, and to provide a forum for discussing these things. Its purpose also includes promoting and fostering international understanding of global issues. WACCI receives support from NPR Illinois, which provides publicity for our programs. This provides residents in the area with information regarding our programs, including the topic, the speaker, the date, the time, and the location for each presentation. In addition, we receive support from the University of Illinois at Springfield, from Lincoln Land Community College, and from Southern Illinois University School of Medicine. Information about the World Affairs Council of Central Illinois and the programs that are scheduled can be found on our website at mywacci.org or on our Facebook page. We have automatically muted the microphone for each of you as you join tonight's Zoom program. For the duration of the speaker's presentation, we ask that everyone please keep your microphone muted. After the speaker has finished his presentation, there will be a question and answer period, and we will explain the process for asking questions at that time. And now I would like to introduce Dr. Bakar Siddiqui, who will introduce tonight's speaker. Dr. Siddiqui is a member of the WACCI Board of Directors and a member of our program committee. Dr. Siddiqui.
Good evening. I'm Bakar Siddiqui, a board member of World Affairs Council of Central Illinois and an emeritus economics professor at University of Illinois, Springfield. I'm pleased to welcome and introduce our distinguished speaker, Dr. Rajesh Govindaya, who, given his background and experience, is eminently qualified to speak and answer our questions on a very timely topic of his presentation tonight: viruses, vaccines, and vaccination, bringing an end to a global pandemic. Dr. Govindaya is Senior Vice President and Chief Medical Officer of the Memorial Health System, where he is responsible for administrative and clinical leadership and coordination for medical staff, graduate medical education, and physician alignment activities. He collaborates with all medical professionals, trainees, and staffs of all the health system affiliates to advance the clinical environment. In addition, he oversees activities to improve patient outcome, to achieve the Memorial Health System's mission to improve the health of the people and its communities, the communities it serves. Dr. Govindaya graduated from the University of Michigan Medical School in year 2000, and in 2005, he completed his residency in internal medicine at St. Joseph's Mercy Hospital in Ann Arbor, Michigan. He joined the Springfield Clinic in 2006, where he served as chairman of the Department of Hospital Medicine until 2010. He continues to practice clinically as a hospitalist. Dr. Govindaya has been actively involved in quality initiatives across the Memorial Health System and has served as co-chair of the Illinois Hospital Association's Medical Executive Forum and as a member of the American Hospital Association's Physician Alliance Executive Forum. He's an associate professor of internal medicine at Southern Illinois University School of Medicine and a fellow of the American College of Physicians. Welcome, Dr. Govindaya. The floor is yours. I mean, the screen is yours.
Thank you, Dr. Siddiqui. Thank you for that very warm introduction. Thank you, Bruce, and to the World Affairs Council of Central Illinois for allowing me the opportunity to speak a little bit today. I'm gonna share my slides and hopefully you can see them. Can you see my, my first slide?
Perfect.
Awesome. Great. I want to talk today about viruses, vaccines, and vaccination and bringing an end to a global pandemic. And I want to start off with just thanking not only WACCI, but also some of my colleagues and for their assistance. Namely, I want to thank Chuck Callahan, one of my colleagues at Memorial, for some of the great pictures that I hope to show you. Lance Milberg, who helps with some of our data, and you'll see a little bit of that. And then also Dr. Vidya Sundaration, who I also bounce some ideas off of on a regular basis throughout the pandemic. So I want to start with a pandemic when we talk about how to bring this pandemic to an end, but I'm actually going to start with the last pandemic, and that is the Spanish influenza pandemic. So here's some pictures from that pandemic from 1918 to 1920. And I want to read to you the sign at the top left. Spanish influenza has endangered the prosecution of the war in Europe. There are 1,500 cases in the Navy Yard. 30 deaths have already resulted. Spitting spreads Spanish influenza. Don't spit. Well, advice from 100 years ago that we can still listen to, don't spit. So what happened with Spanish influenza? First of all, it actually didn't start in Spain, but it's named after Spain because that's where the first news reports came out. It infected approximately 1/3 of the world's population, 500 million people, and had a staggering mortality of somewhere between 50 and 100 million people worldwide. And we think it spread from the picture on the left with troops in trenches, and then World War I ended, and these troops got onto boats and they returned home and they spread it all over the world. So why think about Spanish influenza? Why talk about this pandemic? Well, it's really interesting and really important for us to understand the tools we have at hand to stop our current pandemic. And I want to talk about that for a moment. How do we stop our current pandemic? And we're going to use Spanish influenza as kind of a bookend on some of the things we're doing now. So let's talk about the current pandemic. Right now, the topic du jour is vaccination. And why do we want to vaccinate? It's to achieve this concept called herd immunity. And I want to explain what herd immunity is. This is a graphic from the CDC. And herd immunity is basically when enough people in a population are immune to an illness, either because they've been vaccinated or because they've already been sick, that it makes the spread of this illness very unlikely. And that protects people who have not been sick or have not been vaccinated, like take someone who's too ill to be vaccinated or a new baby, because the population itself, the herd, so to speak, is immune. So if you look at this graphic, the red people are people who are sick and can spread the illness. The blue people are healthy, not sick, but also without immunity, and they are susceptible. And the yellow have been vaccinated and they are no longer susceptible. And the top picture just kind of shows you how someone who's red can spread the illness to someone who's blue, and how if you have lots of people who are vaccinated, that blue person never comes in contact with a red person, and so the disease does not spread. Okay, so that's what herd immunity is. So how do we achieve herd immunity? Well, it depends on this concept called R naught. R zero, but it's actually said R naught. And R naught is a public health epidemiological term used to represent the reproductive number. So what does this mean? It means how many individuals, if I am sick, how many individuals do I go on to infect? And so just kind of simple logic says that if R naught is greater than 1, that I will go on to spread the illness to more than one person. And if I spread it to more than one person and they spread it to more than one person, the disease spreads widely. And that's when a pandemic occurs. And again, remember that a pandemic is a new illness that no one has immunity to that is spreading widely. So how do you calculate herd immunity using R naught? And I want to tell you, I've vastly oversimplified this, but sometimes simple is good. So herd immunity, you use R naught this way. You take this little equation, 1 minus 1 divided by R naught. So if R naught is 3, then herd immunity is around, say, 66.7. So this is different for every illness. Take measles, for example, extremely contagious. R naught for measles is somewhere around 15. The herd immunity threshold is somewhere around 95 to 97% for measles. So again, remember that the R naught for every illness is different. So that begs the question, what is R naught for SARS-CoV-2? SARS-CoV-2 is the virus that causes COVID-19 illness. So you're going to hate this part. Yeah, we don't know. We don't know. We have a guess. Our best guess is somewhere between 2 to 3. Why don't we know? Because in order to know what R naught is, you have to conduct what we would call a natural experiment and let the disease spread widely without taking any steps to stop it. And we've obviously taken lots of steps to stop the spread of SARS-CoV-2, to stop the spread of COVID-19. So you're probably asking, well, why show me this? And there's a statistician by the name of George Box who said, and he was talking about statistical models, all statistical models are wrong, but some are useful. Okay, so how can we use this model? Well, let's start with thinking about all the ways we tried to stop the spread of the virus. All the things that we did 100 years ago. So to prevent influenza, wear a mask, the picture on the left. Thank you for wearing a mask because it helps me protect you and you protect me. Don't believe this happened? Here are pictures from 100 years ago, school kids. And this year, or last year maybe, school kids wearing a mask, or how you get a haircut. I love this picture. It actually cracks me up because the person 100 years ago and the person today are apparently getting the exact same style of haircut. So some things don't change over 100 years. Now it's not just how we go to school or how we get personal services. It's how we got entertainment, right? Baseball 100 years ago, baseball now. One of the neat things about this picture is right above the bat, you can see people in the stands, but those are not people in the stands. Those are cardboard cutouts because of social distancing, which we all know all too well. We also tried to clean our environment. Here's a fumigation process on the left 100 years ago, a little bit more high tech, but the same fundamental principle now. And social distancing. So here's an ad for the guest rooms of the Country House. And what they're really saying is, there's no one else here. It's easy to socially distance. So what am I getting at? We were talking about R naught, how many people one infected person goes on to infect, and all these steps we've taken to prevent the transmission of COVID-19. And I don't know what the normal transmission of COVID-19 would be because I took all these steps to prevent them. That begs the question, do any of these steps actually work? Well, how would I tell? I can look at flu data. What do I mean? I know how flu has spread in the past and how it spread this year when we've taken all of these extra steps. So here's the flu data in the state of Illinois. The colored lines are the last 5 years. Sorry about that, that skipped ahead. These colored lines are the flu incidence in the last 5 years. And this red line is the flu incidence this year in the state of Illinois. Each of the boxes is the most recent week, and you can see that flu is dramatically lower than in prior years. Because guess what? All of the actions we've taken to prevent the transmission of COVID-19 actually prevent other viruses too, like influenza. So this is pretty compelling. Let me show you something from Memorial Health System, which is 5 hospitals across central Illinois, with the flagship hospital here in Springfield, but hospitals also in Decatur, Taylorville, Lincoln, and Jacksonville. We have taken all of our flu testing data from all of that, all of our sites of care, and we've compared it last year versus this year. And we do this monthly, and flu season starts October 1st and goes through the end of March. So through the end of January, last year, 2,013 cases, this year, 29 cases. We have 1% the number of flu cases. And what you don't know, but I do because I've seen this data, is in December to January, I can see the change in the data. Last January, we had 1,000 cases of flu. This year, we had 3. 3. That is just staggering. And guess what? The number of people vaccinated is not significantly different. It's the number of other mitigation, the mask wearing, the social distancing, all of that other stuff, having a tremendous impact. Why is this important? Because it helps us think about R naught, this number of reproduction. So if R naught decreases, then the number of people that you have to immunize to get to herd immunity, that goes down as well. And if R naught increases, then herd immunity threshold goes up. Why is this important? We started with an R naught, I don't know, of 2 or 3, and we did all of these things to prevent the spread. And that pushed R naught down, maybe to call it 1, 1.5. But if we ever want to stop these things, stop the masking, stop the social distancing, stop having distant birthday parties, how you celebrate birth or death, then R naught's going to go up. And that means our herd immunity threshold also goes up. Okay. So I hope that makes sense. So what is the goal of vaccination? Why vaccinate? To achieve herd immunity. But why do we care about herd immunity? It's pretty simple. We want to end the pandemic. We want to put this behind us because let's face it, we're all tired of this. I'm tired of it. You're tired of it. And if you're telling me you're not tired of it, you're probably lying. Or I'm going to believe you're lying. So how do we end the pandemic? Well, I want to start with just talking about vaccination. And in order to understand vaccination, you have to understand what a virus is. So this is a picture, an electron micrograph of the coronavirus. And so viruses are really, really tiny. You need a microscope, or in fact, even beyond a microscope, they're submicroscopic organisms. Some of them cause illness, some of them don't. And they're basically little packages of genetic material and they're surrounded by a shell. And this is a picture of that shell. And what this virus does is it attaches to your cells, it enters your cells, and it hijacks your own cell's machinery to make copies of itself. So a virus cannot replicate by itself. It needs another host to replicate. And these pretty little spikes on here that you see, this is why a coronavirus is named a coronavirus. These spikes were meant or felt to represent or mimic the corona of the sun. So you can kind of see the sun in the middle with these spikes on it. And that's why it's called coronavirus, because of the corona of a sun. So this virus enters your body, it hijacks your cells, it opens itself up, it gives you its instruction kit, a cookbook, so to speak. It makes more copies of itself, and it makes you sick. Okay, so that's what a virus is. So how does a vaccine work? Here's kind of a cross section of that same coronavirus. You can see the spikes in that shell, and then you can see the genetic material inside. So the vaccine basically trains your immune system to recognize the virus quickly. And by training it, if you're exposed to it, your immune system can kick in and stop the virus before it really causes an infection in you. Now, there's lots of different types of vaccines. Some, and we'll talk about them in a moment, but they all train your immune system in some way. And so when enough people are vaccinated or immune due to vaccination or illness, you get herd immunity. So what sort of vaccines are out there? I borrowed shamelessly several slides from the New York Times. They do a great job of summarizing this data and this information. There's other great websites out there too. The Wall Street Journal does a very nice treatment on many of these topics as well. But I find the graphics on the New York Times to be really nice, and so I borrowed them. So this is from today. They have a coronavirus vaccine tracker. The website is at the bottom. And this kind of shows where different vaccines are in the process of development. Right now, there's 6 or 7 vaccines being used across the world. And there's over 70 that are under active investigation. And there's several different types of vaccines. And this is really important to understand the different types of vaccines because it helps us understand how we might deploy them, how long it takes to make them, and so on. So we'll start in the upper left quadrant, the genetic vaccines. These vaccines take a little fragment, not the whole genetic instruction, not the whole cookbook, but call it one page of the cookbook of how to make the virus. And they take just that one piece. And they take that one little page, that one little instruction set, that's that red little squiggly line right here, and they put it in a little container, an envelope, so to speak, and that's what you get. And these are these mRNA vaccines that have been approved for use in the United States, the Pfizer and the Moderna vaccine. They use this technology. And I'll come back to that in a minute, but I want to talk about the other vaccines. Below, you have this viral vector vaccine. These take a virus that does not cause an illness, and they put that information inside of it. So they use that same mRNA fragment and they put it inside of a virus that does not cause illness, and that's what's injected into your body. So you're getting typically it's an adenovirus with some additional information in it, and this helps train your body to recognize the virus. What happens is when these two vaccines go into your body, that mRNA then enters the mRNA enters your cell, and your cell produces lots and lots of those coronavirus proteins, those spikes, and then your immune system learns what those spikes look like because they're exposed to it. Now, there are a couple of other vaccines under development. One is these protein-based vaccine. So instead of injecting you with the mRNA and having your body make the spikes, these spikes are made outside of your body, and then you're injected with them and your immune system recognizes them. And then the final type is this inactivated or attenuated coronavirus vaccine. And this is where we grow actual coronavirus and then inactivate it or neuter it, for lack of a better term, sterilize it so it cannot reproduce. And we give that to you. And so just for full disclosure, flu vaccine actually uses this process. And we grow flu virus in eggs, and then we sterilize it or we weaken it, and that's what you get. Now, why is this important? Because it takes a long time to make the vaccines on the right, because you have to make all of those proteins or all of those viruses, and it takes 90 days to make a flu vaccine. These genetic vaccines on the left, they are made much quicker. And that's why the Pfizer and Moderna vaccines came out first. But they've got some problems. This little envelope that the Pfizer and Moderna vaccine ship in is super fragile. And because of that, they need to be shipped at super cold temperatures. So these are the types of vaccines. Now, you might be asking, well, why is any of this important? Well, quite frankly, this pandemic has affected the way we get and receive medical care. The same thing happened 100 years ago. Here are people, healthcare workers, wearing masks. They're not wearing gloves, but on the right, we're seeing again wearing masks when you provide care. You're seeing how the care is provided in wards where we have these temporary wards. On one, I think that's actually a ship. On the other, that might be a place like the Javits Center in New York or the McCormick Center in the state of Illinois. So the way we've sought medical care has changed dramatically. So we should vaccinate people. Now, the good news is across Memorial Health System, we vaccinated over 9,000 people. Some of these are community members. Some of these are healthcare workers who got priority access to vaccination. I am a healthcare worker and I got vaccinated. So yes, I actually did get vaccinated. The needle is actually in my arm. The person giving it to me is one of our infection preventionists, Gina Carndiff. Gina has been instrumental in our COVID response across the health system. And so she was really excited because I'm her boss, really excited to give me a shot. So Gina did that. I got my first dose on December 31st. And I've luckily had my second dose of vaccine. And I hope many of you have begun that vaccination process as well. But we saw an interesting trend when we started doing vaccination. There's a discrepancy in people who want vaccination. So our colleagues, these are the 9,000 plus individuals who are employed by Memorial Health System across central Illinois. They're only adopting vaccination at about a 62% rate. My medical staff, these are my doctors, my advanced practice nurses, my physician assistants, they're adopting vaccine at a much higher rate. And we were curious as to why this is happening. And I think, quite honestly, they're answering a different question. Colleagues are making a decision of, is the vaccine good for me or not? And the medical staff are asking the question, how do I get immunity to COVID-19? And they've realized there's only two ways to get immunity. One is to get vaccinated. The other is to get COVID-19. And they're making the very rational decision that they would rather get vaccinated than get COVID-19. So you might look at that 62% and say, well, geez, that's terrible. You should do better. I will tell you that this is a national number. We are seeing the same thing across health systems in central Illinois and nationally. So there is a degree of vaccine hesitancy, to the point that the CDC, they have a weekly newsletter called Mortality and Morbidity Review Weekly. And they published this last week, COVID-19 vaccination intent, perceptions, and reasons for not vaccinating. And I realize this is hard to read, but I'm going to read some of the highlights of this. Individuals who are less likely to choose vaccination. Younger adults, less likely. Women, less likely than men. Black individuals, less likely than non-Blacks. Individuals living in rural areas, less likely than people living in urban areas. Adults with less education, less likely than those with a higher education. Adults with lower income, less likely than adults with higher income. And then individuals without health insurance, less likely than those with health insurance to get vaccinated. Now, we've dug into our own data at Memorial Health System. All of these trends hold true. There's one that I cannot identify, that is educational status. I cannot identify that. And the rural, actually in our colleagues, the uptake is the same whether you live in a higher density census tract zone or a lower density census tract zone. But all of the other stuff is the same. That there is vaccine hesitancy amongst a wide variety of our population. Now, one of the things that is fascinating is the correlation between income, because this doesn't only occur at the individual level, it's actually playing out at a global level. So this is from The Economist, it's from December. Rich countries will get access to coronavirus vaccines earlier than others. So there is a heterogeneity here, an inherent inequity that is occurring at a global level and at a national level, and within certain populations within our own community. That's really troubling. So I want to talk about this in kind of two ways. The rich countries will get access to corona vaccine earlier than others. I want to talk to you about it. One, why are rich countries getting access? But also some of the inequities we're seeing worldwide. So one of the reasons rich countries are getting access is because countries like the United States funded vaccine development and pre-reserved vaccine. So I guess good for us. And in many ways, good for the world because we fast forwarded the process of developing vaccine. But there's another reason. I'm going to go back to the way the vaccines were developed. Those mRNA vaccines, they're very fragile. They require super cold refrigeration or cold refrigeration. And guess what? That just doesn't exist in many parts of the world. Even in our own community here in Springfield, even amongst our own health system, we have 5 hospitals. Not every one of our hospitals has a super cold storage capacity. And so some of our hospitals are storing them at other hospitals just because these super cold freezers don't exist. So you're seeing that in part because these mRNA vaccines came out first, and they can only be used where you have good refrigeration and electricity. And some of these newer vaccines, like the viral vector vaccines, those are stable at room temperature, and those become much more usable in other parts of the world, or even in rural parts of the United States. But there's another inequity, and Israel is actually a great example of this. Israel did something really unique with Pfizer. They went to Pfizer and said, we want priority access to vaccine. And they basically agreed to 3 different things to get priority access to vaccine. And so Israel has now vaccinated more of its population than any other country. What are the 3 things they did? They said, we'll pay a premium, we'll pay extra. They said the next thing is we are ready to vaccinate day 1. So if you give it to us, we will roll it out quickly. And number 3, we will give you data on our entire population who has been vaccinated so you know how well your vaccine worked. And so when you think about individual autonomy in the United States or individual privacy, those are just non-starters to share your own health data, even if it's blinded, to a global multinational company so you can get vaccine earlier. Now, Israel's interesting because they have applied their vaccine heterogeneously. If you're an Israeli citizen or live in Israel proper, you get access to vaccine. If you live in the Palestinian territory, which some may say Israel is responsible for, and I don't necessarily want to get into that discussion, but if you live in the Palestinian territories, you don't have access to vaccine. And so there are all of these kind of moral hazards that are occurring globally, and not only, but also in the United States. And Israel also has individuals who are saying, well, we're not going to get vaccinated either, for a whole host of reasons that may be similar to the United States or may be unique to Israel. But this is a global problem. Now, this is from 2 months ago, mid-December. Has it actually happened? Did rich countries actually get access to coronavirus vaccine earlier than others? I would say yes, because when you look at vaccine tracking across the world, the top graph from the New York Times, total vaccine doses administered worldwide, 185.4 million. The middle bar is from the CDC's COVID-19 data tracker. The middle number, total vaccines administered, 57.7 million. This is as of today. So I want you to think about this for a minute. The CDC is saying that 57.7 million vaccines have been administered in the United States, and worldwide, 185 million have been administered total. So that means the United States is somewhere like, 32% of all vaccines administered worldwide. We don't have 32% of the world's population. Maybe it's 4. So there's inequity there. And, at the bottom, I just said, how many doses have been administered in the state of Illinois? We're creeping up on 2 million. We're doing about 450,000 a week in the state of Illinois, 1.6, 1.7 million in the United States. Now, here is a very promising number. You see that total vaccines administered, 57.7. More vaccine has been administered than we've had confirmed cases of COVID-19 in the United States. That's that number on the in the middle on the far left, 27.7 million, basically. So what's the practical impact of this? And so this is where some of our data analysis has come to play. So these are some numbers from Memorial Health System that our data team has scrubbed. So I want you to look at the top, that 50%. When we look at Central Illinois residents age 65 or over, we can look at the total population of individuals over 65. And we've determined that basically half of them now have immunity due to COVID-19 because they've either had illness, that's about 14,000 people, or had COVID-19 vaccination, that's about 42,000 people. So it's about half of Central Illinois residents over the age of 65. Unfortunately, 58,000 plus remain at risk because we don't know if they have immunity. They haven't been vaccinated, and we don't know if they had COVID-19. So what does that translate to in practical numbers? Well, we know of the individuals 65 and older who had COVID-19 that over 700 died in Central Illinois who are over the age of 65. I suspect some of you know them, some of them. These are friends and colleagues and community members of yours, of mine, of ours. But of the individuals who got vaccinated, that's likely somewhere around 2,200 prevented deaths. That's a huge number. But it also means that of the unvaccinated, there's another potential 3,000 deaths that could be prevented if we vaccinate. So this is really important, not just globally or nationally, but locally, even in our own neighborhoods. So I want to step back again and take us back to the Spanish flu pandemic, because a lot of people died then too. And this is actually data from the United Kingdom from 1918 and 1919, where they saw 3 different waves of mortality. So they thought they had it under control. They relaxed on their mitigation measures. They had a peak. They relaxed, they got it under control, they relaxed again, and they had another peak. And you might say, well, what the heck does this have to do with us? So let me show you mortality. First in central Illinois in our, or I'm sorry, not mortality, the number of new cases. Well, before I do that, let me just say that this graph from the United Kingdom broadly corresponds to waves that we're also seeing globally. So this was, I have data, or this graph is from the UK, but actually this happened worldwide. And we can see a similar story, not in deaths, but in the number of individuals infected. This is Memorial Health System, 16 county service area. It's basically Sangamon County and the surrounding counties. And what we saw. And we escaped that spring peak back in April, but other places didn't. Chicago didn't, Detroit didn't, New York didn't. In the summer around August, we saw a peak in Florida, Georgia, Texas, Arizona. And then the bulk of the country saw a peak in the winter. And then in our area, we saw a peak in November, peaked a little earlier than most of the US. But then we saw this little bounce coming out of Christmas and New Year's. But thankfully, our cases have gone down quite a bit. Now, in the United States, we saw this kind of early peak, this middle peak, and then now this later peak. Again, our peak here in central Illinois in November 11th was about, I will call it 4 weeks earlier than the peak in the United States, but roughly similar. And here's the price. Statisticians calculate the number of expected deaths each year, and then they look at whether the expected number of deaths and the actual number of deaths was above or below average. You can actually see that back in 2016, the deaths were below average. In 2018, we had a particularly bad flu season. We had more deaths than expected. But since the COVID-19 pandemic started, 500,000 excess deaths. Now, not all of these are due to COVID. Some of them clearly are. Some of them likely are because someone had COVID and we didn't know it and they expired, they died. And some of these are because people delayed or did not get healthcare they needed because of the pandemic. Some of these are due to suicide or drug abuse or depression, things that have all gone up during the pandemic. So there's been a brutal toll. And it actually plays out in the US life expectancy. If you go back to US life expectancy since 1860, you see a dip at the Civil War, you see a dip with the Spanish flu pandemic in World War I, and actually life expectancy has declined again. And when we think about the challenge of this, the pandemic and the public health mitigations became political. And that's a true tragedy, because I think it impaired our ability to deal with the pandemic. And this is not the first time this has happened. 1918, Anti-Mask League calls mass meeting to protest. And then this year, last year, the new symbol of tyranny, a muzzle. Social unrest, riot sweeps Chicago. Protests give rise to chaos. And stop the slaughter of innocents. Protest against compulsory vaccination. And now, save my right to die, my virus, my choice. But ultimately, I think we recognize that healthcare is important. Some might call healthcare a human right. I would say access to vaccination during a pandemic is a human right. And so ultimately, how do we bring an end to a global pandemic? Well, there's really just three ways. The virus mutates and becomes less lethal. We're seeing the virus mutate, although it's not clear that it's becoming less lethal. Or effective treatments or vaccines are discovered. We found a vaccine, it works really well. It's kind of a pain in the butt to administer, but it works really well. But we don't have effective treatments. You might read about them, but man, they're really not that good. Probably the most effective treatment is these monoclonal antibodies. But think about it. Would you rather get vaccinated and have your body make antibodies, or would you rather have antibodies grown in a lab and injected into you? I trust my own immune system, so I'd rather get my own immunity. Or finally, the population acquires herd immunity, which is what we were talking about with mass vaccination programs. And ultimately, I will tell you, the way to bring an end to this pandemic is through vaccination. Vaccine does nothing. It's the use of that. It's about community. The choices we make affect more than just us. They affect everyone around us, everyone we come into contact with. And so we need to remember that, because the way we think about how to take care of one another is the way that we will end the
Thank you so much, Dr. Govindaya. We really appreciate your support to WACCI and making time this evening to share your knowledge with us. My name is Jolene, and I'm the Vice President of WACCI in charge of programming, and I will be moderating the Q&A portion of our evening. We have about 10 to 15 minutes or so for our discussion. And as in our past WACCI events, we will be using the raise hand function in Zoom to facilitate the Q&A. So depending on which version of Zoom that you have will depend on where the raise hand tab is located. If you have the newer version of Zoom, you can find the raise hand tab on the bottom row of your screen if you simply click on reactions. And if you have the older version of Zoom, you will need to click on participants, which is also in the lower row of your screen. Once you click on participants, you will need to find your name, and you will see the raise hand button next to your name. So if you have a question, please click to raise your hand. I will do my best to call on participants in the order that you raise your hand. I do apologize in advance if I'm a little out of order, but once I call your name, you may then unmute yourself and ask your question. Please only one question at a time. And once your question has been answered, please mute yourself again, and we will move on to the next person. So now please raise your hand if you have a question for Dr. Govindaya. Okay, I am not seeing any hands raised at the moment.
Dr.
Naomi
Naomi.
hand raised.
Barbara, do you see anyone with their hand raised?
Naomi Lynn has her hand raised.
Just a physical hand, not her actual hand, or not a.
Okay. Okay, we prefer if you can use the raise hand function and not actually raise your hand, because I'm looking at the participants list. And
Am I unmuted now?
okay, you can go ahead, Naomi.
Okay, a question I had, it has to do with the immunity after you've caught a coronavirus. In some areas of the country, they're suggesting that even though you've had the virus, you go ahead and get vaccinated, and they are doing it. And then the second part of the question is, you have had coronavirus, how long should you wait before your full recovery and you accept the vaccination?
Those are great questions, Naomi. So here's why. So first of all, if you've had coronavirus, the CDC and others recommend that you get vaccinated. Why? Because everyone has had the individuals who got coronavirus, it's unclear how long their immunity lasts. We think it lasts 90 days, but we've seen individuals with another infection. We also know that people with very mild cases may not develop as much immunity as you might get with vaccination. So we recommend through our own vaccine clinics that if you have had coronavirus, that you do get vaccinated. If you want to wait, you can wait up to 90 days, 90, after you had coronavirus to get vaccinated. But at that point, you should get vaccinated.
Thank you.
Of course.
Okay, and if you have a question, just a reminder, either click on the reactions tab at the bottom of your screen and then click on the raise hand tab. Or if you have the older version of Zoom, please click on participants and you will see the raise hand function next to your name. Professor Siddiqui, or I'm sorry, Bruce.
Yeah.
Yeah, talking about vaccinations and immunization, one of the questions that I've heard discussed is, what is the expectation after you have the vaccination for the immune system to be effective? For how long?
Yeah, so there's kind of two questions there, or two things there. The first is, when does the vaccine really start to provide benefit? So what we've seen, at least in the clinical trials, is that even after the first shot, there's some benefit, but the full benefit of vaccination occurs 14 days after the second shot, or when you've completed the series. And right now, people won't like this, but it's the truth. This has all happened so quickly. We do not know how long immunity lasts. We know it's after vaccination, we're confident it lasts at least 3 months. And the CDC is actively looking to see how long it lasts. My hope is that it lasts at least a year. And I think there's some beginning evidence to suggest that it will. But, the long term of this is, we don't know how long the vaccine will last, how long the immunity benefit will last. Because quite honestly, there aren't that many people who have been infected for a year, and there's no one who's been vaccinated for a year.
Thank you.
Thank you.
Dr. Siddiqui?
Yes, I have a colleague who could not be here and asked me to raise this question. People who are taking that Pfizer and Moderna, requiring 2 doses, what's the likelihood of needing 3rd doses to cover the variants that medical professionals are talking about?
Yeah. So right now, first of all, the variants, I want people to understand that variants are going to happen. This is just biology. The virus is going to mutate. It's going to change. And some of those changes will make it more infectious or make the vaccine not as effective. We know that these vaccines still provide protection against the variants. Initially, the projections were that it would take about 5 to 7 years for the virus to change enough that you would need a different type of vaccine. I would say that I think the virus is changing a little bit faster. One of the reasons it's changing faster, and this is a chicken and the egg problem, the more people that get infected, the more opportunities the virus has to mutate. So because we had so much illness, more mutation occurred than we thought might originally happen. Of all of these variants, the most concerning variant that would escape the vaccine, so to speak, is this variant in South Africa. It has more mutations than the Brazilian, the Californian, or the UK variant. Those are all pretty well, the vaccine provides benefit. Even with the South African variant, it provides, the vaccine still provides benefit, but not as much. And that's why they're talking about a potential additional shot to help you learn the variant, so to speak. I hope I answered your question, Dr. Siddiqui.
Thank you. So this is very different from last year. We typically have more than enough questions, but I'm not seeing many hands raised at the moment. If you do not have audio, you can type your question in the chat. We were planning to give priority to those that raised their hand. But does anyone else have any questions for Dr. Govindaya?
Barb Mullaney has one.
Yeah.
My husband and I are due to give blood, and we're both getting our second shot. So should we wait a week to give blood, or should we do it right away? What's your suggestion?
Yeah, so I think, so first of all, thank you for donating. That's very generous of you. I think the initially blood banks were had some restrictions on if you vaccinated, if you could give blood. I think they have removed those now. I will say that there are some side effects after these vaccines, and you may not feel great. I personally had my first dose December 31st and my second dose January 28th, 28 days later. I did not really feel great January 29th. I wouldn't have wanted to go and do much. And I think I'm hearing that, from, that's not uncommon. So you might want to pause because of that. But as far as I'm aware, there's no prohibition on you giving blood because you've been vaccinated or not been vaccinated.
Okay, I do have a question here in the chat box. This is from Steve. After you get 2 vaccines, can you travel safely?
Yeah, we've been looking at the CDC guidance on this really carefully. They have not changed your guidance, but here's what I would tell you. We talked a lot about quarantine. If you're exposed to someone who has COVID, you should quarantine. There are really a very few exceptions to quarantine, and I'll just try and tell you what they are. If you've had COVID in the last 90 days, you don't need to quarantine, you're presumed immune. And if you've completed your vaccination series in the last 90 days, you do not need to quarantine if you've had an exposure. We think this means that the CDC will provide some guidance on travel if you've been vaccinated. But they haven't done it yet. I don't know if they will. So, your guess is as good as mine. But your risk in traveling would be, I think, quite a bit lower. And then also remember now that if you travel internationally, you need to get a COVID test in the 72 hours before you board your plane to return to the United States. And so that's something to keep in mind as well. And the reason for that is they're really trying to look for these COVID variants and prevent them from coming into the country, although quite frankly, they're already here.
Bruce, I see that you have your hand raised. Did you have another question?
Yes, I do. The question is the significance of the timing between a first shot and a second shot. Whether that, we've heard 3 weeks, I think, with one of them and 4 weeks with the other. Is that a maximum amount of time that should be between the two, or a minimum amount of time that should be between the two?
Yeah, so understand that this is based on how these clinical trials were designed. The Pfizer trial was designed with 21 days between injections, the Moderna trial with 28 days. There's actually a Johnson & Johnson vaccine that is a single shot that may be coming in the next several weeks. So in terms of the timing, the trials were based on that time frame. But the reality is not everyone in the trial got it exactly on those days, and there is some wiggle room there. I would suggest you get it as close to those days as possible, but sometimes that's not possible. The tolerance is 4 days before or up to 2 weeks after. Although you will drive the healthcare professionals crazy if you try and if everyone tries and does that, because right now the challenge we face is getting supply of vaccine in a predictable way. And when we have it, we want to use it in a predictable way. And when people start moving 2 weeks later, it makes that a little bit harder to do. But it doesn't have to be exactly 21 or 28 days.
Thank you.
Okay, we have another question in the chat box. This one is from Rochelle. Regarding the anti-vaxxers, how confident are you that medical community and scientists will be successful in persuading those folks to get vaccines? And how difficult has it been battling misinformation out there?
Yeah, fair question. I'm not. Let me explain why. If we can fight about masks, I think we can fight about anything. And unfortunately, a lot of people have operated from kind of a libertarian ethos. Do not tell me what to do. So it's no longer, in my opinion, about the mask or the vaccine. It's about my individual personal freedom. And, I think that's just a different dialogue. That's honestly, there's nothing medical in my answer. I'm just giving you my own personal thoughts on that.
Jolene, there's another question.
Yes. Hi, Mary. I see that you have your hand raised. You can go ahead.
Yes, thank you. Bringing this back to a practical point that maybe other of you might be experiencing. 4 weeks after I will have had my second vaccination shot, I anticipate that I will have a parent and grandchild coming to visit me to look at schools in the area. All right, am I more of a danger to them, or are they more of a danger to me? And how should we still mask and keep distances?
Yeah, wow. I don't know how they're traveling. I don't know where they're traveling from.
They'll be flying from California.
Yeah, right. So, here's what I would say, Mary, is masks really do work. The flu data is just so compelling, in my opinion. And our own experience inside the healthcare system with appropriate personal protective equipment, these things really do work. You are likely protected. They are more likely a danger to one another than they are to you or you to them. And the way they travel and the individuals they interact with during their travel is probably their greatest risk.
So basically, I plan to wear a mask, but what they plan to do themselves is up to them, and that won't be more harm to me if they don't choose to wear a mask.
Yeah, I think you've already done the two best things you could do to protect yourself, which is get vaccinated and wear a mask. They can. So remember, mask wearing protects those around you because it prevents you, if you're sick, from spreading the virus. So you wear a mask not just for yourself, but you wear it for everyone you come in contact with. And so they're wearing a mask protects each of them, and it protects you as well. But if they're coming to stay in your home and everything else, my goodness, it's hard to do that stuff.
Jolene, did you get the one?
Okay, we have one more question in the chat box, and then we have one more hand raised, and then those will be our last two questions. The one in the chat box from Andrea: could you explain the difference in how children are thought to transmit the virus under age 12 and over age 12? Is there a difference?
Yeah, I'm not sure I really understand this all that well. I do think there is there's a couple of theories out there. One is basically that that the younger you are, you're relatively asymptomatic, and you do not have as high a viral load. The other is that maybe the way you breathe, and we call the amount of air that goes in and out of your lungs the tidal volume. That tidal volume is lower, and you don't project the virus. You don't spew the virus around as much. But candidly, I have not really paid attention to the pediatric literature because I quite frankly haven't had the time. But you're right to point out that the incidence of illness is lower in children, and the number of outbreaks that have been associated in a school place setting have been rather low with distancing and mask wearing in even elementary school settings.
Okay, and our final question comes from Dr. Siddiqui.
Yes, I know there are community members in different groups who are not going to take vaccine at this time because of mistrust or misinformation or lack of access. I'm just curious what Memorial and others, or they have any plan to reach those communities, and what actions you're contemplating if you are.
Yeah, so take that CDC data that I showed. We've looked at the same internally, and we're thinking, how do we target those individual groups within our own colleagues, our own community, our healthcare community? And quite frankly, the same things we would do there, we would do to the broader community. But I think this is hard, right? During the pandemic, Memorial made a very intentional decision to be very transparent with its data. We wanted to be viewed as a source of trust, that if you wondered how many people are in the hospital, you didn't have to, we would tell you. So we've done that from day one, and that's been intentional because we wanted the community to look to us as a source of reliable information. And so we are actually on our website and, through events like this, quite honestly, through the radio, through TV, through media, trying to get this message out there. But man, there's a lot of noise and it's hard to do. And I think a lot of us live in our own social media bubble or our media bubble. And if you're in a bubble with crazy information, then that's all you're going to see. And it's hard to penetrate that bubble. So we'll try, but it takes all of us. It's not incumbent on me just as an individual. I think it's incumbent on all of us to spread that message of how to take care of one another.
All right, well, thank you again, Dr. Govindaya, and thank you everyone for your excellent questions. That was a really good discussion. I am now going to turn things over to Bruce for our closing remarks.
If I could just say thank you to the WACCI. Thank you, Bruce. Thank you, Dr. Siddiqui. I've really enjoyed the opportunity, and I hope you found it worthwhile. Thank you so much.
Thank you. Bruce, you are muted.
Okay, that was certainly an informative presentation. Thank you, Dr. Govindaya, for sharing your knowledge and expertise regarding a topic that we all have been absolutely consumed with during nearly all of 2020 and will probably continue to be through most, if not all, of 2021. On behalf of the WACCI Board of Directors, I want to say thank you to those of you in the audience for your support of WACCI. WACCI is a volunteer organization and relies on the membership donations to pay expenses for providing speaker programs. If you wish to join WACCI or to renew your membership, you may obtain a copy of the WACCI membership form on the WACCI website at mywacci.org or on the WACCI or in the WACCI newsletter. The WACCI mail address is available on both of those documents. We have 4 speaker programs scheduled for the remainder of the current business year, and I'll very briefly give you some information about those. On March 3rd, the title is The Hacker and the State, And this is a presentation of little known details regarding how China, Russia, North Korea, Britain, and the United States hack one another in a relentless struggle for dominance. On March 24th, the title of the program is Global Climate Change. The speaker will discuss questions such as what is climate change and how serious is it? How do we know climate change is real? What will the impact of climate change be locally and around the world? And how can individuals make a difference? April 13th, the title of the program will be Rising to the Challenge. Our speaker will discuss the problems related to oceanic pollution and the hazards of waste from all around the world. This includes the connection and interactions between humans, pollution, and environmental change on the local and global scale. And then our last program of the current year is on May 3rd, and it's titled Why Protest? And the speaker will discuss political processes, political parties and democracy, and political behavior. That concludes tonight's program. Again, thank you all for participating, and I wish you all a good evening and a good night.